All right, so we're going to talk about immunology and hematology this morning. And we're going to look, first, when we talk about hematology and immunology, we need to look at the blood cell. We need to know what we're looking at. So if you pull out that first diagram, the first thing we're going to look at is platelets. What do platelets do? Clot, right? So they're normally 150 to 400,000, and they're responsible for clotting. What happens if there's too many platelets? Yep, clots. More clots than we should. What happens if there's too little platelets? We bleed, right? Then there's red blood cells. Red blood cells should be 4.5 to 5.5, and they carry your oxygen. If you don't have enough red blood cells and you're not able to carry oxygen, that's when your tissues and your cells can't function because they're not getting enough oxygen. Within the red blood cell count, you're going to see a retic count, and these are the immature red blood cells. Your bone marrow makes these immature red blood cells. So if you have a low retic count when you're looking at your CBC, then it's telling you that there's something wrong with the bone marrow. It's not able to make those immature red blood cells. If you have a high retic count, that means that the bone marrow is cranking out immature red blood cells, right? So something's going on where there's either your body has low RBCs or the RBCs are being destroyed and your marrow is saying, oops, we got to get into gear, start making more red blood cells. So things like sickle cell anemia, which we're going to talk about, they'll have a high retic count because their hemoglobin is being destroyed and they're having to make new ones constantly. Your MCV and your MCH are just the size and weight of the red blood cell. We don't get into that too specifically in this course, but they'll talk about like hypochromic, microcytic anemias. You'll hear those terms. That's what the MCV and MCH tell you. Your hemoglobin, oh, I have this really fast, sorry. Hemoglobin should be 11.5 to 15.5, and it's the number of red blood cells. So the number of red blood cells within the plasma is your hemoglobin. The crit, on the other hand, which should be 35 to 45, it's always about 3 times your hemoglobin. So if you can see 11.5, if you times that by 3, you get 35. 15.5, you get times 3 is 45. It's the percent of percent of RBCs in the plasma. So hemoglobin is that actual number of RBCs. Hematocrit is the percent compared to everything else. So let's say you have a situation where you would increase the plasma volume, but the number stays the same. Your crit would go down, right? Because if your volume is bigger, but your number stays the same, it's a percentage to it. But if you have destruction of RBCs, then your hemoglobin would go down, because it's the actual number. Yep. So because hematocrit is a percentage of the number of RBCs, if you have a situation where your number stays the same, but your volume increases, it's almost like when you get a dilutional hyponatremia, that it's going to be the same kind of concept. So because it's that percent of volume, whereas the hemoglobin is the actual number of RBCs. Your white blood cells, what do? Fights infection, right? And they should be 4.5 to 13.5. And when we look at a white blood cell, we are looking at all of these things. white blood cell. Particularly, we want to look at what they call a shift. You know, you'll hear a shift to the left. That often, it tells the difference between a bacterial and a viral infection. And basically, we're looking at neutrophils and bands when we're looking at a shift. So your ANC is the body's ability to fight infection. And there is a way to figure it out, and I'm totally blanking now. There's a little formula, but we don't need to get into that for this course. You just need to know that if the patient has a low ANC, that means that their ability to fight infection is low. So often your patients on chemotherapy, they'll do ANCs to see if they can even receive chemotherapy if their body's strong enough for it. Bands are immature neutrophils. And like I said, those are more with bacterial infections. You'll see that shift to the left. Eosinophils are often seen elevated with inflammatory disorders. Neutrophils is the primary defense against bacterial infections. So again, you'll see that shift to the left, they'll be elevated.
You said primary defense was what? I'm sorry.
Against bacterial infections. Monocytes often are elevated in inflammatory reactions. Basophils often increase when there's an injury to the area. And lymphocytes help develop antibodies. So it's a good idea to understand basic principles of what you're looking at when you get a CBC, and if there's an abnormal, what's going on with the body.
Under the eosinophils, what is your writing in the box?
Inflammatory.
Okay.
Increase with inflammatory.
Could you say the writing for the monocytes, the basophils? It's hard to
Yeah.
see with them.
Yeah, the monocytes is the inflammatory reaction. Increased. Baso typically are elevated when there's increased blood flow to the area because of injured tissue. And lymphs help develop antibodies. All right, so when we're looking at the hematological function, we want to get a really good health history. What could possibly be causing a dysfunction? Does the patient complain of any fatigue? What's the patient's diet like? Do they bleed easily? Do they get frequent infections? All those things that we would want to know because our CBC will help guide us. We want to get a good health history to add to it. Physical assessment, we look at skin. Are they, pale, right? If we don't have a lot of hemoglobin, what's our skin going to look like? Yeah. What's going to happen to our heart rate? Increase, right? It's going to increase. Yeah, because it's going to compensate because it's got less hemoglobin, so less capability of carrying oxygen to the body, so it's going to beat faster to get more cells, more oxygen to more cells faster because it doesn't have enough in the drop it has. They might bruise easily. They might have petechiae. Lab data, we talked about the CBC. We also want to look at iron because iron is help develop RBCs. Coag studies to help us in combination with platelets for bleeding. All All right, so anemias in general, they have a low hemoglobin hematocrit, low RBCs, so they're not able to carry oxygen as well to the body. It can be caused by different things. It can be caused because either we're not making red blood cells, something's wrong with the bone marrow, they're not making it, something's wrong with your iron, it can't make red blood cells. It can be because red blood cells are being destroyed, or it can be because we lost blood. So if we look at our little diagram that you guys have, what is it in general? Low hemoglobin, low RBCs. It can't carry oxygen to the body. Why? Because either red blood cells aren't being made, there's blood loss, or the red blood cells are being destroyed. So what clinical manifestations are we going to have? If they're not getting oxygen, is this patient going to be full of energy, happy, or is it going to look like all of you after a test?
Yes.
It's going to be fatigued, right? You said we already talked about their heart rate. They're going to be tachycardic because they're trying to increase the body's ability to get oxygen out to the tissues. They're going to be pale. They're going to have some shortness of breath, possibly. They might feel lightheaded. Why? They're not getting oxygen, right? Not getting oxygen to the brain. So think about what happens in your body when it's not getting the oxygen, because with anemia, those red blood cells aren't able to carry as much. They could have some hypotension if there's been blood loss, and that's what's causing. They might be irritable, any CNS changes because their brain is not getting enough oxygen. They could have a heart murmur. Poor peripheral perfusion, so they may have, their cap refill may be slower, their pulses may not be. And they can be jaundice if those red blood cells are breaking down faster than the body can, what's the word? Thank you, process. And long term, if this isn't corrected, they could have problems with their growth. So how do we diagnose this? Obviously CBC, right? It can tell us that hemoglobin, it can tell us the hematocrit. We need to know iron. We need to know coag studies. History is going to be really important. Again, are they fatigued? Do they have frequent infections? Are they bleeding? Also, when we talk about sickle cell, we'll know like ethnic background or thalassemia. Those are important to know the patient's ethnic background because certain conditions are more prominent. And physical exam. Again, what does their skin look like? What are their vital signs? Do they have any bruising or petechiae? Mm-hmm.
I noticed in the hospital they test for TIBC, total iron binding capacity. How do you do that?
I think that's kind of beyond the scope of what you need to know here. I can't tell you exactly how they do it. I know that they do it in children more frequently, but
They do it in children, or they're not?
they can do it in children. They can do it in adults. And it's basically, I'm trying to say, how can I say this without confusing? I would just say that it's beyond probably what you need to know in this scope. Okay. I can look it up more and try to figure out a better way to explain if you want, but I would say beyond this is what you need to focus on. All right. Okay. So treatment, you want to treat any underlying cause. If your patient's bleeding, make them stop bleeding. If there's a reason why red blood cells are being destroyed or why they're not making enough, we want to treat that underlying cause. We want to give them oxygen because we want to make sure that the red blood cells that they do have are able to give out as much oxygen as they can. Like I said, blood if they need it, IV fluids, and then rest. If your body's in a hypermetabolic state, it's going to need more oxygen consumption, right? So we want to let them rest so that they're not having to have as much oxygen demands on their body. So this is anemia in general. We're going to look at a couple specific ones, including iron deficiency anemia. So this is a decrease in the red blood cell production. And it's normally caused because there's no iron in the diet. All right, so RBCs aren't being produced because there's a lack of iron. How do we diagnose it? Yay! CBC. Why? Who's at risk for getting iron deficiency anemia?
Babies.
Yeah. Premature babies, definitely.
Elderly.
Low social economic status, elderly. And a lot of times it's these kids that are like 1 to 3 years of age. Either they're 6 months and they're breastfed and their mom stores have run out and we don't supplement and they're not getting it through their diet because if they're breastfed, they're not getting those iron fortified formulas. Or they turn 1, they go off breast milk, off formula, and they go drink whole milk. And for those who have kids, you know that they can suck down like a jug of milk a day. And they're not getting iron from other sources in their diet. So whole milk, because instead of formula, like I said, the 6 months of age, they start losing those iron stores. And adolescents also tend to develop some iron deficiency anemia because their diets suck. They eat chips and candy bars and don't get a lot of green leafy vegetables and other good iron sources.
Is that low SES?
Yes, socioeconomic status. So just like with anemia in general, what are some clinical manifestations you're going to see? Fatigue.
Pale.
Yeah.
Do you see like the dark circles under the
You
eyes
can.
too?
Raised heart rate.
Tachycardia, right? Raised heart rate. Pallor, you guys said that. They might be heavy because they're eating the wrong things. So they may have a diet that's full of, like I said, chips and candy bars and things that are high in calories but not necessarily high in nutrients. They may have some shortness of breath, like we said, fatigue. And long term, if this hasn't been corrected and no one's been following up on it, you might even see clubbing of the fingernails. But those would be late signs. Initially, you're going to have a child, like I said, that's kind of pale in color, that's kind of tired and tachycardic. So what do we want to teach these patients?
Proper nutrition.
Nutrition, diet, right? If they're not getting iron, give it to them. So we need to teach these adolescents things to eat. If they don't like their choices, come up with some alternatives for them. Tell parents of breastfed babies that they need to be on an iron supplement at 6 months. Remind parents that have switched to whole milk that they need to make sure that their child's getting other sources of iron. We can give medications. Has anyone actually read ahead or no? I know you're all gonna laugh at me when I say that. So with medications, iron supplements, they will not be absorbed if you give them with milk. The milk binds to the iron and they just excrete it. So if you give your patient an iron prescription and just say, here, take it, most of the time, when do you take your meds? When you're eating, right? And most people think, take meds with eating so that it protects the stomach. This is one case where that would not be good because that milk, especially if they're milk drinkers and that's why they're iron depleted, the iron's going to bind to it and it's going to inhibit absorption. So we don't administer it with milk. What should we administer it with? Vitamin C, right? Orange juice. So typically we tell the parents, make sure that you're giving this iron with juice or with a piece of fruit in between meals. So like a snack. Also, let the parents know about the side effects. They might get a little, because we're not giving it with food, they might get a little GI upset. It might stain their teeth. So especially with little kids, now granted, they're going to lose their primary teeth and get new ones. So if you stain them a little bit, it's okay.
Use a straw.
But we should kind of squirt it towards the back of the mouth or use a straw for them. And also, we know it's working when their stools turn tarry green. And that's a good thing. So we want them to have these tarry green stools. And parents will freak out. They'll call the pediatrician and come running in to say, there's something wrong with my baby. Their poop is green. But that's actually a good sign. These patients need follow-up. Constipation, GI upset, stained teeth, the tarry stools.
But if the stool is blackish, then that's bleeding? Or
It could be an indication of bleeding. But yeah, that wouldn't be a side effect of iron administration. And that's not a side effect that we want. It's like a tarry green. It's greenish in color. A black would indicate maybe a bleed and would need further investigation. So we want to make sure these patients follow up. Typically 1 month after treatment, they'll get a repeat CBC and they'll continue to get CBCs to check and make sure that we're correcting the problem. And education is going to be big. We need to tell them how to prevent by making sure they have a good diet and that all children get screened. Typically we start at 9 months and we check it every year during their well child checks through adolescence because adolescents are high at risk. All right, so pretty straightforward. Any questions with that? All right. So sickle cell anemia is another anemia, but this one is an inherited disorder, autosomal recessive, and basically the red blood cell becomes sickled. So Dr. Chastain has used this example, and I think it's a great one. So if you can kind of visualize in your mind, everyone been on a lazy river, right? Okay, everyone really, yep. We all like our lazy rivers, yeah. For your birthday. All right. So everyone knows those inner tubes, right? You sit on the inner tubes and they're nice and squishy and round and you're going down the lazy river and there's no problems. And you know, that part where everybody enters and it like gets clogged up, but it's no problem because your inner tube kind of can squeeze together and squeeze past someone and you can move around, right? They're nice and squishy, they bounce off of each other, you can kind of squish them and move by someone. It's no big deal if like all of a sudden like 50 people get in and the wave goes faster, you just kind of go with it. Now imagine sticking a bunch of kayaks down that lazy river. Those kayaks are squished, they're hard, they don't maneuver as well. So now imagine where you get to the stair part and you have like 50 people that are coming in with their kayaks. Are they going to be able to flow very well? No. Imagine anything that, during the lazy river, there's always those bends and areas that constrict. Are those kayaks going to be able to turn very well or go down that flow? So someone with sickle cell anemia has red blood cells that kind of form kayak-like, and they get stuck during different times. So it's a defect in the hemoglobin, a sickled shape, and there are things that trigger it. So anything that triggers this normal, round, squishy hemoglobin to become sickled is going to cause what we call like a sickle crisis. So anything that causes narrowing or vasoconstriction. So if they're in pain, if they're cold, if they're dehydrated, anything that's going to make that lazy river smaller and make those kayaks hard to get through. Anything that's going to make it more populated. So if all of a sudden 50 people enter from the stairs because, the school field trip just unloaded at Adventure Island and they're all running, anything that's going to have more cells, like exercise, right? When we exercise, we get that blood flowing, right? Like at Orange Theory, right, Bree? Infection, high altitude, anything that's going to produce more cells and kind of clog the area. Or anything that makes that flow faster. Because when it flows, remember, if you're in your kayak and you're okay, but all of a sudden the flow goes faster, your kayak might turn and get stuck. So anything that makes that flow faster. Heat, stress, exercise, fever. All of these trigger these cells to become sickled and get stuck. And basically they obstruct the capillaries and stop blood flow from getting peripheral to that area. So when we talked about that it's autosomal recessive, I like to draw it like this, but you could do it the way you have it in your book too. So you have, in order to get it, both parents have to have the gene, right? So you have a mom who's got AS is the sickle gene and a normal gene, and a dad who has a sickle gene and a normal gene. So when you look at it, this child is going to get a sickle gene and a sickle gene. They're going to have the disease. And I'm going to do it on here so that when you guys listen to it, you'll be able to see it. So right there, they get the sickle and sickle, they get the disease. This child gets one normal gene, right, the little A, but they also get a sickle gene. So in order to have the disease, they need to have both, right?
But they're carriers.
So that child is a carrier. This child down here gets one little A and one little S. So just like the other child, they're a carrier. And this kid, I feel like I'm saying this little piggy, and this kid gets one little A and one little A, so they are disease and trait free. Okay? So when a mom who has the gene and a dad who has the gene make a baby, they have a 1 in 4 chance of having the disease. They have oops, I'm sorry. They have a 2 in 4 or 50% chance of having the trait. And then a 25% chance of having a child who has neither the disease or trait. So it's just kind of like playing a game of roulette. You don't know, but that's the percentages of their child having the disease or the trait. And they can, like I said, they can only get it. So if the mom has the trait and the dad is fine, then they can't get it. They may carry the trait, but they can't get it. And this is predominantly in African American, I was going to say females, but females or males.
So 1 in 4 chance of the child having the disease.
Mm-hmm.
Okay.
Yeah.
So like, they could have one child that has the disease and one child that doesn't if they're.
Every time it resets. So they could procreate 7 times and get 7 children with the disease. This is just a,
None?
or they could get none. This is a percentage per pregnancy.
Oh, okay.
So it doesn't decrease. So like if next time they have a child, it's not like, oh, I already had one, so my 25% is out the door. This is
Each time
percentages
has
per pregnancy. Yep.
And if one parent only is the carrier, then they won't have it.
They will never have the disease, but they will always be a carrier. So at most prenatal visits, the mom is tested. If the mom is negative for sickle cell, they don't test the dad. They don't even worry about it. But if the mom comes back positive for sickle cell, then they test the dad. And they test everybody because although it's predominantly African Americans, because of genes and everything, or if you have biracial parents, you have the chance of having it. So they go ahead and test.
How long have they been testing?
I don't know the exact time. I know when I got pregnant 10 years ago, they tested me. So I believe it's been a bit.
So then what? Like if they know this person will have sickle cell.
They don't know if, they just know that the parent, so mine was part of my prenatal. Before I even got pregnant, they told me that I wasn't a carrier. So, but they will, so if people go to prenatal visits, now if they're already pregnant, then there's nothing they can do at this point. But it's often done prenatally before they even get pregnant to see if they're at risk. And then the parents can decide what they want to do. Obviously, we don't ever encourage anyone from ever not having children, but they should know their percentages or the chance of. Huh? Yeah. Mm-hmm. All right. Oh, I skipped over a slide, but that's okay. So diagnostics, newborn screening. The infant metabolic screening. We want to diagnose it as early as possible because we want to prevent complications. The more complications this child has, so the more crises where their cells become sickled, they obstruct their capillaries, and they lose blood flow past that, the more chances there are to have poor outcome. So we want to decrease the number of sickled crises as much as possible. So we test them at birth. It's part of the new infant metabolic screening, that IMS. We get CBC. We can get blood cultures. What's going to happen to the retic count?
It's going to go down.
Oh, you poor listener. It's going to go up. Thank you for taking a chance. It's going to go up. Why? Because these sickled cells are getting destroyed and they're blocking, and the marrow is saying we need normal red blood cells to carry that oxygen to the body, right? So that marrow is going to start cranking out these immature red blood cells, so the retic count's going to go up. They can get a hemoglobin electrophoresis, which is just a more in-depth way of looking at the hemoglobin. And like I said, the retic count. So these patients are going to have all the signs and symptoms of anemia. They're going to have fatigue. They're going to have increased heart rate. They're going to have that breathlessness. But these patients get pain. They get arm and leg pain. They get back pain. They get joint pains. Why are they in pain?
They're not getting enough oxygen.
Yeah, they're not getting blood. It's infarcting, basically. So long term, if it's not treated, anything past that area of blockage is becoming infarcted, and that's extremely painful. That area is not getting oxygen, and so it's dying off, and that patient's feeling dying off tissue. It's painful. And it can be very mild or it can be very significant. They often have splenomegaly because their spleen gets engorged just because of the way it's like the bendy parts of the lazy river, and it's very easy for these sickle cells to get stuck in the spleen. They oftentimes have to have their spleen removed just because of the risk of it getting so engorged that it ruptures. They can get priapism, which is everyone aware of what that is? No. Basically, they get, I know I hate saying it because I feel like a 5-year-old. They get a prolonged erection for longer than 4 hours, and it's very painful because it gets, basically, again, the sickled cells get stuck. I know I'm like a 5-year-old. Can you tell I deal with kids? I know. Where's my penis? So, all right.
Sorry, I asked.
Yeah. And then, I know, I'm like sweating now. And then swelling.
She was hoping nobody asked what that was when she was doing it.
Uh-huh.
She's like, so you can put it on there.
How do you know that?
Priapism, Priapism. You're going to make me focus on it now?
It's like DNA.
It's hard to write with a little bit. All right, so what are the complications? They're all secondary to this obstruction of the small blood vessels. So it can cause engorgement, ischemia, infarction, hypoxia. They can have those vaso-occlusive episodes with the sickle cell crisis. Like I said, they often get where their splenic, it kind of sequesters in the spleen, and their spleen becomes engorged, and then, like I said, infarcts and dies off. They often have to have their spleen removed. They can have an aplastic crisis. A big one is the acute chest syndrome. If you have a patient that has sickle cell disease and they're complaining of chest pain, they need a chest x-ray because, again, the small blood vessels get clogged.
Does it say what, chest syndrome?
Acute.
Oh.
And does it say 2 obstruction?
Secondary to.
Okay.
It's my shorthand.
Aplastic.
And crisis.
Crisis, thank you.
So the big thing is with treatment, it's going to be on the next slide. You'll see it. Is there's no cure. Parents need to understand that the biggest thing for these kids is prevention of a crisis. You want to keep them well hydrated. You want to, during times of stress, help keep them calm. If they have an infection, treat with the appropriate antibiotics if necessary. If they have a fever, give them Tylenol, Motrin to get the fever down. So hydration. We really want to keep them hydrated, right? Because anything that causes narrowing of your lazy river is going to cause those kayaks to clog up. So the more wide we can keep that lazy river, get that fluid going, the less likely they are to have a crisis. Same with pain management, antibiotics. Vaccines are important for these children. We don't want them sick. When they're sick, they go into crisis. Education for these parents is really important. And we want heat, not ice, right? Because what's ice going to do? Vasoconstrict, right? So heat's going to help. So heat is always a great therapeutic thing for them when they're feeling uncomfortable or at the beginning stages, even during bad stages of their crisis.
I thought the heat raises the flow and we don't want too much flow or something.
You don't want too much flow, but during times of crisis, that when they're vasoconstricted, the heat helps. Vasodilates and helps it. With this small episode, we can do NSAIDs like ibuprofen, Tylenol, and PO opiates like codeine. During more severe crisis, this is when they need IV pain meds like morphine or Dilaudid. And again, bed rest is going to be really important for these patients. We don't want them to be up exercising or doing anything that's going to increase their oxygen consumption or increase that flow. So if they're up and they're stressing their body and they're exercising, that's going to make the occlusion worse, the crisis worse, and the pain worse. So we really want to make sure that they have bed rest to decrease their O2 needs. We can give them oxygen through a nasal cannula, transfuse if we need to. If they need electrolyte replacement because they're sick. And we need to observe for any metabolic acidosis because if they're hypoxic, they are at risk for developing it.
If we transfuse them, the new blood gets
No, but you will use up those RBCs. I mean, transfusion just helps temporarily. Your new blood cells are still sickle because it's an inherited disease. So their blood, there's just a defect in their hemoglobin. So they're always going to have hemoglobin that are kind of like kayak-like, that are squished and hard and don't work as well. I did find let me see if I can find that picture. I did find this. You kind of see it right here. That theory with the squishy inner tubey looking on the top, and then more of the sickled cells on the bottom and how they can clog so that anything distal to that. I wonder if I think I can add it up here. Is that too small? It's kind of tiny, huh? All right, any questions about sickle cell? So some nursing diagnosis, they're at risk for altered peripheral perfusion. They're at risk for fluid volume deficiency, pain, risk for infection, especially if they get their spleen out, right? They're at higher risk for infection, and lots of knowledge deficits if we don't educate. But this is, can you see this crisis that this poor child's having? They get really, I mean, they're red, they're swollen, they're painful. All right. Thalassemia is when your erythrocytes aren't producing, they're ineffective production of your erythrocytes. And your RBCs are being hemolyzed, and the ones that are there are microcytic and hypochromic, meaning that they're small and they have less hemoglobin. And this is more in Mediterranean families. And I'll go to your little slide. So it's an abnormal formation of the hemoglobin. Your erythrocytes aren't being produced effectively. RBCs are being hemolyzed, they're being destroyed. The RBCs that are there are small and can't carry a lot of hemoglobin, and they die off faster. That's why they're being hemolyzed. So when you're looking at a hemoglobin, it has 4 proteins on it. It has 2 alpha proteins and 2 beta proteins, or you don't need to understand all that except for that. That's why they have the different names. So they have different forms of thalassemia, because if an alpha is affected, so you've heard thalassemia B, and have you heard of that? So if an alpha is affected but your betas are normal, or both alphas are affected, or one beta is affected, that's where you get your different forms of thalassemia. For the purposes of this class, you don't need to get into all of that, but just know that there are different forms. So there's minor, which is basically having the trait and just passing it on. Intermedia, and then major, which is what we're concerned about, which is the Cooley's anemia. And this is a severe anemia where the patient needs lots of transfusions, right? Because they have these red blood cells. The ones that they have suck. They can't carry a lot of oxygen. They're small. They get destroyed frequently. They have a short lifespan. And they're not able to make a lot of them. So they need frequent transfusions in order to get the hemoglobin that they need to transport oxygen to their body. So again, this is autosomal recessive. It's an inherited disorder. So back to that box. So if you look at this right here, you have minor and then normal, and minor and normal, right? So both parents have to have the trait. So there's a 1 in 4 chance that, because 2 minors equal a major. There's 50% chance that you're going to have a minor. And then there's a 25% chance that the child's not going to get the trait or the disease, right here. And this is more common in Mediterranean families. So let's look at diagnosis and clinical manifestations. We diagnose it at CBC, right? So we're going to, remember we talked about the MCV and the MCH, and that was the size. Those are going to be low with this patient. Obviously their hemoglobin's going to be low. Hemoglobin electrophoresis. And radiographs, because these children, because of their lack of oxygen, they often have bone deformities, skeletal deformities. As we remember, we said if long term the patient's not getting enough oxygen, they are at risk for growth problems. Again, what are signs of anemia? Pallor, tachycardia. They can have failure to thrive because they're not getting that oxygen they need to develop. They have severe anemia. So this is not just a little anemia, this is a big anemia. They get jaundice. What's happening to all those red blood cells that are there? What are they doing? They're breaking up. And the body can't process, thank you for that word, process them fast enough.
So this is worse than sickle cell?
I wouldn't say it's worse. It's just a different type. They're both,
Equally severe.
So they get this iron overload. And I'm going to butcher this, hemosiderosis. Oh, that says, this is hepatosplenomegaly. Sorry, mine is in a different order. Here it is. HemOnc. And the HSM is the hepatosplenomegaly. They often have the facial and skeletal deformities. On your slides, you can see from your PowerPoint, you can see what a typical child looks like that has the and we're talking with Cooley anemia. These are most of the signs and symptoms with Cooley anemia. And they get this very bronze, freckled skin. And that's also because of the iron overload. Most of their complications, their morbidity and their mortality, come from their severe anemia and from the iron overload because they get a lot of cardiac and hepatic complications. So treatment, they get lots of blood transfusions, and their blood transfusions actually cause a secondary disease for them because they get this iron overload from getting so many treatments. So they have to have the iron, I'm going to butcher this one too, chelation therapy. So we need to get rid of all that extra iron. So one, we want to promote compliance. Again, there's no cure for this. This is something the child has to live with long term. We want to give them prophylactic antibiotics because they are at increased risk for infection. Oftentimes have to get their spleen out. And those blood transfusions can cause that secondary disease. So we need to remove all that extra iron from the blood. And it's typically done with a sub-Q drug, Desferal. And it basically binds to the iron and the body can excrete it. These patients can't live with the blood transfusion, they cannot live without the blood transfusions, but because they're getting so many of them, it's causing a lot of secondary complications. So that's why they call it a secondary disease. So they have to be treated for this iron overload, or they have even more morbidity, mortality, and complications. All right, you guys have any questions? Ready to take a break? You guys look very excited. I know this is rough.